Hello everyone, and a warm welcome to the launch of this report into a survey of people with inflammatory arthritis across Wales that we conducted in the autumn of 2024. And just to make you aware, we are recording this webinar for future sharing. I'm Peter Foxton and I'm the CEO of NRAS, and I'm joined today by my colleagues Ailsa Bosworth, our National Patient Champion, and Sadé Asker, Senior Policy Officer, who will take us through the report, and then I will pick on some of the key discussion points and talk about them in more depth. We're delighted also to be joined by Dr. Ceril Rhys-Dillon, Clinical Lead for Rheumatology Clinical Implementation Network in Wales. We have a lot to get through, so we may not have time to answer questions at the end, but we will do our best to leave some time. But if you do have any burning questions, then please do put them in the chat and we'll try and get back to you later, or we'll get to them in the questions. The full report will be available to download from our website in English or Welsh after the webinar, and that's www.nras.org.uk. And without further ado, I'm going to hand over to Ailsa, who's going to talk through the methodology of the report.
Thanks, Peter, and good afternoon, everyone. So we last conducted a patient survey in Wales back in 2016. And at that time, the BSR were doing a State of Play in Wales report, having surveyed their membership that year. We both therefore felt it would make sense for us to add our data to the State of Play report, giving a more complete picture of rheumatology services. Following receipt last year of some funding relating to Wales, we decided to prioritise a further survey using some of the same questions as last time, but also adding some new ones. And the survey ran from the 1st of September to the 13th of October last year. We also particularly wanted to understand the impact of COVID on different groups and to identify areas of need where we could add value for both people with inflammatory arthritis as well as the rheumatology teams looking after them. To be eligible for the survey, next slide, thanks. To be eligible for the survey, participants needed to be 18 or over, live in Wales and receive care through a Welsh NHS health board and have a diagnosis of inflammatory arthritis. The forms of IA included were rheumatoid, adult JIA, axial spondyloarthritis, psoriatic arthritis, undifferentiated arthritis and palindromic arthritis. And the responses were all collected anonymously. We emailed everyone with IA on our database, advertised through social media, and also created flyers which were sent to all of the units in Wales to give to patients with details of how to take part. We also advertised in the national press, although this route proved not particularly effective. We're grateful to the National Ankylosing Spondylitis Society and Versus Arthritis, who also advertised the survey through their networks. We had two sets of questions with common questions for both, one for less than 5 years diagnosed and one for more than 5 years. There were questions on initial diagnosis and continuing access to care, specialist support and comorbidities, and defined questions on access to supported self-management, as well as collecting demographic data. 650 people responded, of which 424 were eligible responses, which is a considerably higher response than we had in 2016. The majority which were not included were due to having an ineligible condition. So I'm now going to hand over to Sadé to take you through some of the top line results.
Thank you, Ailsa. When we were analysing the results from the survey, taken from the specific questions and also a free text response, it was clear that there were really important statistics which highlighted a range of issues, which we were able to separate into 3 distinct categories. The first is diagnosis and access. This is your initial access to the GP, access into secondary care, and waits between appointments. The second is around specialist support, and this is not just internal NHS specialist support, but also the lack of signposting to patient organisations. There were issues around the room for improvement that people felt with their condition, a high percentage of people with comorbidities, coupled with a low use of annual reviews and a lack of support around exercise. And the final section was around education and self-management. I'm going to go through each of these questions in a little more detail, highlighting some specific results from our questions. Diagnosis and access. The reference here to newly diagnosed are the group diagnosed less than 5 years ago. We identified some issues in accessing the system for individuals who have suspected inflammatory arthritis. 36% of people found it difficult to obtain a GP appointment, and nearly half of people found it difficult to obtain a GP appointment. Nearly half of all people had to see their GP more than 3 times before they received a referral to secondary care. From referral, only 22% were seen within 6 weeks, 20% of people waited over 18 weeks, and a further 21% chose to attend privately due to wait times. This is showing a trend of people waiting longer for appointments. When coupled with issues in accessing the GP and obtaining a referral, there is the potential for a significant delay between symptom onset and access to rheumatology for a diagnosis. Even when people have accessed specialist care through rheumatology, we also saw significant waits between appointments. 28% of those newly diagnosed have not seen their consultant in over a year, rising to 43% for those diagnosed more than 5 years ago. In connection to that, we had expected to see a rise in the use of PIFU, patient-initiated follow-up, but patients reported in the survey that only 18% had had a discussion about PIFU with their team. The final point on the slide, which was identified within the free text responses, relates to nurse advice lines. We had a free text box at the end of the survey where people could enter their comments. We had well over 200 responses, but the most common issue was around not being able to access any advice over the phone or being told to contact their GP or 111. The next theme was around specialist support. This is a mixed section outlining that people don't feel they have the specialist support they need to manage their condition well. We saw a high percentage of people not being referred to support from patient organisations. 56% of newly diagnosed said they were not signposted at all, and 74% of those diagnosed more than 5 years could not recall being signposted. There were a number of questions centred around how people feel about their condition and how it's managed. Only 7% of those diagnosed 5 years or less felt that they completely understood their disease at the time of diagnosis. This rises only nominally to 13% of people living with inflammatory arthritis for more than 5 years who feel their condition is well managed. When you couple that with not being signposted for supported self-management and the previous slide, where people are not seeing their consultants for over a year, it's really concerning that people don't feel their condition is well managed. Finally, we also asked about whether people felt they had a joint which required surgical opinion, and a staggering 40% felt that they had a joint that needed surgical review but had not been offered one. In addition to the inflammatory arthritis diagnosis, 72% of all people reported having another condition, but only 15% felt that their care was as joined up across different specialties. People also reported a low use of annual or periodic reviews, with 75% of all people saying that they had not had a review since they were first diagnosed. Finally, we asked about physical activity, and 41% of people said that their team never asked them about exercise during appointments. The last theme is around education and self-management. At NRAS, our focus is supporting people to learn about their disease and become good self-managers with the right support. And this is critically important given the statistics in the previous slides. Within the survey, we gave information about what supported self-management was and then asked a range of related questions. 50% of people felt that they did not know all they needed to about managing their disease. And when you link that back to the previous points about how only 7% of newly diagnosed individuals felt that they completely understood their disease, and 85% of people not undertaking any kind of remote monitoring between appointments, this raises concern. When we asked if people wanted access to supported self-management, a majority, 68%, said that they would welcome it, and a further 18% not knowing what supported self-management is. This is certainly an area where we can be part of the solution. As I mentioned earlier, in addition to the questions, we allowed individuals to write any comments, and we had well over 200 responses. I've pulled out some of the most common responses. These relate to appointments, nurse advice lines, comorbidities, and access to a wider multidisciplinary team. Many of these are already reflected in the questions and percentages I've just read out to you. I'm going to hand back to Peter now to go through the discussion points in the report.
Thanks, Sadé. So lots to think about there in the results from the report. It's clear that waiting times remain an ongoing problem, and whilst there are things that we can do to support the rheumatology teams, which I'll talk about a little bit later, workforce issues, which are a major part of that, are not something that we can fix. However, we are supportive of the ongoing British Society for Rheumatology workforce campaign, and we have already been working with the Strategic Clinical Network for MSK Health within the NHS Wales Executive, and fully intend to continue that collaboration to support the development of pathways of care in rheumatoid arthritis and juvenile idiopathic arthritis, and the network's commitment to value-based, patient-centred healthcare, and hope that over the coming months we will start to see the waiting times reducing. Also, part of our new 3-year strategy, which will be published soon, includes a commitment by us to raising more public awareness of both rheumatoid arthritis and NRAS as an organisation, and the support that we provide. So we will be continuing to raise awareness of the early signs and symptoms of disease and the need for people to help seek advice early. In an era of long waiting times overall, the introduction of patient-initiated follow-up (PIFU) pathways where people are seeing their team less and having longer intervals between appointments. It's crucial that people are given education, accurate evidence-based information, and access to supported self-management resources. And our survey indicates clearly that this is not happening widely enough. This is an area that is also being highlighted by other key organisations, such as a report from the Welsh Parliament's Health and Social Care Committee titled Supporting People with Chronic Conditions, published in January this year, and also the long read from the King's Fund of a blog by Sophie Randall, CEO of the Patient Information Forum, regarding key third sector organisations, the role that key third sector organisations such as NRAS have to play in supporting people living with chronic conditions. She said third sector organisations can act quickly, be more agile, and respond to unmet needs that the NHS cannot address, and this is certainly true. We understand that healthcare professionals want to support their patients to the best of their ability, but a big part of that is knowing how and where to refer and signpost people to high quality sources of help, and there is a great deal of expertise which resides within patient organisations like NRAS that health professionals can tap into for their patients. On this slide, at the top, you can see that the management of disease very much correlates with other surveys and sources of data, such as our national helpline, and that this needs to be considered, along with the fact that only 7% of individuals felt that they completely understood their disease following their initial diagnosis. Rheumatoid arthritis and inflammatory arthritis are complex diseases, and it takes time and effort on the part of the individual to acquire good knowledge and understanding of their disease, its treatments, and the kind of lifestyle adaptations which are needed to be made when living with inflammatory arthritis. This is a major area where we can help, and is one of the main reasons we recommend signposting patients to our Right Start service. I was able to present on this at the Rheumatology Clinical Network meeting in Powys earlier this month, and you can find out more about Right Start on our website. Just click the Right Start button on the home page. If you then take into account the fact that the vast majority of responders in our survey are not undertaking any kind of remote monitoring between appointments, and the lack of periodic reviews where risks of comorbidity, things like heart disease, would normally be measured, the system is creating problems for further down the line and not focusing on prevention. We are very much hoping that the work of the relatively new Strategic Clinical Network for MSK Health within the new Wales Executive is going to start to improve things for patients with inflammatory arthritis. And I think on that note, I'll hand over to Ceril, who's going to talk a little bit more about the network and the plans for Wales.
Thank you very much, Peter and Ailsa and Sadé, and thank you for the invitation. So my name is Ceril. I'm a rheumatology consultant based in South Wales, but I'm here as the clinical lead for the newly formed Clinical Implementation Network. It's a mouthful. We shorten it to CIN, and the CIN was formed last November, and it forms part of an MSK team that is now housed within the NHS Wales Executive. And within that MSK team, rheumatology sits alongside spinal surgery, orthopedics, persistent pain, and bone health. So who sits on the CIN? What is it? Well, it's a group of individuals all trying to improve outcomes for patients who need rheumatology services within Wales. And it's made up of the clinical lead for rheumatology within each health board, the allied health clinical lead for Wales, paediatric clinical lead, represented from the Rheumatology Training Committee for Wales and from the clinicians group of rheumatologists within Wales. And soon to be, within the next month or so, we'll have a member of from the lived experience group, so that we've got patient organisation and patient lived experience within our structure as well. And since November, we've met with other clinical leads from other networks all over Wales to try and reduce the silo working that NHS systems are often accused of. And we've sort of put together a 5 to 10 year vision of how to co-produce and co-design services in Wales to improve. So before we can do that, we need data. And that's where we really welcome reports such as this from NRAS, and data specific to Wales, because we do have a different demographic and we are governed differently as a health service. So specific Welsh data is really valuable. So thank you very much, NRAS, for putting the effort into getting us this data. But there are other sources of data as well. There's been a recent report published by CEDA in conjunction with Lupus UK, looking at lupus services in Wales. And we're also part of the National Ankylosing Spondylitis Society Time to Diagnosis audit. So we're getting data there as well. And coupling that with the data that comes from the BSR, who are currently leading on the National Early Inflammatory Autoimmune audit over Wales. We can now get Welsh data from that as well. So a lot of things have happened in the last 6 months to give us Welsh numbers. So what have we learned? Well, the messages coming through from these various reports are very similar. We're not doing as good as we should be doing. Patients are not being seen quickly enough. There have been improvements made, and we're seeing time to diagnosis and time to remission has been improving steadily. But what we're also seeing is that whereas some areas in Wales are improving, some are getting worse. And so there is this variability across Wales, which cannot be. We need to really reduce variation in Wales. And when we dig deeper to see why these variations happen, we see that it's really closely linked to workforce. So if you imagine a small rheumatology unit might be made of maybe three consultants with 2 or 3 nurse specialists working together. So if you have a retirement or illness or maternity leave, you lose one of those clinicians, you're potentially down to half your workforce very quickly. And so this often explains the variability that we see. So we really need to work better with the NHS exec and the workforce team to make sure that we've got depth in our numbers, so that we're not so open to these variations, because every time there's a variation like this, it's patients who suffer. So that's one of the first things to come out. This report and the results highlight how fragile our services are for some of the reasons I've explained, but it also, there's a really loud message that patients don't understand their conditions, they don't know how to self-manage, and that we as health services are not signposting people. People are reporting that they're not getting these important messages. So as part of the CIN work, we are, for the first time really in Wales, working much more closely with third sector. And our meeting last month, we invited many of our third sector partners, and it was a really useful meeting. It doesn't sound like it's groundbreaking, but this hasn't happened before, so I do welcome this. And one of the things that we really want to work together to change in Wales is that when we see patients, instead of writing back to the GP or to the other specialist who might have referred that individual in, we will now start writing back to patients. Now, I can't promise this will happen tomorrow, but what I can say is of the rheumatology services in Wales, at the minute, there is only one consultant in Wales who is doing this. So there's a huge area for improvement here. So we've got workshops planned with versus arthritis and with the BSR in Wales to help us as clinicians know how to structure our letters in a way that is acceptable, meaningful and useful for our patients. So patients in Wales will start to receive copies of their letters with this year. And that, I think, will improve services. It'll allow us to show that we are able to offer a more personal service and that patients know better how to access help. Because often we might say something in a consultation, but we do know that only 30% of what we tend to discuss in consultations is often retained. So even though it might have been discussed, it might not be retained. And a week later, why would somebody remember every detail of their very busy 10-minute consultation? It doesn't make sense. So we need to communicate much better to enable people to know how to access help and how to self-manage better. So that, to improve that relationship and that communication between the clinical team and the patient and cut out the middleman. So what else does the report tell me? Well, PIFU and the annual review, that's one of the other key themes that comes out to me from this. We've been encouraged to go for PIFU, so patient-initiated follow-up, where it's the patient who decides when they need their appointment. That makes really good sense. Not all units in Wales are doing that as yet. But on the other hand, we're being asked to provide an annual review for our patients who have a very high number of comorbidities. Now, if we're putting people on a PIFU review system, that means they might not call for an appointment for 2 years, which means they definitely won't be getting their annual review. So I do think we need a conversation about which is better and what our patients need. The other thing that strikes me from the demographic of the people who have entered into the survey, and the fantastic numbers, by the way, 480 patients, that's wonderful. 40% of those patients who responded have a higher degree. That doesn't quite fit with our sort of perception of our patient population. So who are we missing? My worry is that we are missing a group of patients who are not accessing these surveys, who are not accessing help in the same way. So whereas we can learn a lot from these results, I think we also need to make sure that we appreciate this doesn't cover everybody. So I think that's really important. I'd really like to compare the demographic of your survey, the people who've done the surveys, with the population in Wales, and to see where the mismatch is, because I think we've got to be careful who we're targeting as well. So I'll stop there, but I'm very happy to answer any questions.
Thank you, Carol. And yeah, I definitely take your point, and I think it's key point for us as well is to how we access those people who currently aren't responding to us or engaging with us, so that we can reach out and offer the kind of support that we offer, as well as encouraging them to take part in these kinds of surveys and gathering information. And as I said before, yeah, we look forward to being part of the clinical network and working with your teams to improve signposting and to improve access to services of all the voluntary organisations which look to support people with inflammatory arthritis. So just to quickly kind of do some acknowledgements before we move on to questions. So there's a few people I'd like to acknowledge. All the people obviously who took their time to participate in the survey. I hope some of those people have joined us today so that they can hear the results, but we'll also be reaching back out as well to those people with access, so that they can access the report and read it in their own time. I'd like to thank the health professionals who promoted the survey to their patients, and to the NRAS staff who were involved in conducting and delivering the report and the survey, and also to the to NAS and to Versus Arthritis our kind of fellow organisations in this field who shared the survey and have confirmed that they will also be sharing the report. And I should also mention the National Lottery Community Fund for Wales, who, whilst they didn't directly fund this report, are funding some work that we're doing alongside it in Wales, and will be continuing to do this year around being a bit more on the ground in Wales and trying to engage more directly with people who want to access our services. So it's always really great to have support from our key funders like that. So I will now move on to questions. I'm not sure, I can't see any in the chat at the moment, but I'm relying on our IT person out there to tell me if there's anyone who'd like to ask a question.
Maybe I can kick off while they're looking for the questions there. One of the things that struck me about the questions that you asked, one of them was, how often do you see your consultant? And there's a lot of the results relate to some of the free text messages. I haven't seen a consultant in 5 years. Now, obviously, we work within a MDT team. And so seeing a consultant isn't necessarily a reflection of what needs to happen for a patient to receive the best care. And I wonder whether what the opinion is in regard to that, because if a patient doesn't see me personally for 5 years, for me, it often means because they don't need to see me, because they've been seen by the specialist nurses, by the physiotherapist, or in primary care. But I'd like to think the patient would have access if there are complex needs that need consultant input. But it's just looking at the language that we use there, that we do embrace the MDT team, and that we ensure that the patients that we see understand that we have other members of the team who can provide the appropriate and best services often, and that may not always be the consultant.
Yeah, no, I totally take your point there, Carol. And you're absolutely right. It might be that it's more appropriate that they see the nurse specialist or another member of the MDT. But we did ask also how long it was since they'd seen their nurse specialist. So we did ask that as well. I don't think we actually asked that question of all the individual members of the team. We have done that in previous surveys to get a feel for how many people are actually seeing other members of the team. But I think on this occasion, we just asked about the consultant and the specialist nurse. But I take your point. It doesn't necessarily mean that if you haven't seen your consultant, that's automatically a bad thing. I agree.